Hi, good afternoon, everybody. Today we are going to present a presentation on the malignant bone tumors of the hand. And I'm Yusuf, one of the registrars of orthopedic in Biopsy Hospital. I know it's a pretty big topic, but we'll concise it to bone, and we might leave out the other skin and the soft tissue malignant tumors. So we start with an overview. So of all the tumors which are in hand, approximately 1 to 2% are malignant, and we classify them as either primary tumor of the hand and the metastatic. So the primary includes three categories. The first one is the skin tumors. They are the 90% cases of all the malignant hand tumors. The second is the musculoskeletal, includes the bones and the soft tissue. And the third categorizes only soft tissue tumors. While for metastatic, we have certain organs of the body which are responsible for spreading tumors from their part to the hand. The leading one is the bronchogenic, the lung cancers. Apart from that, we have kidney, prostate, uterus, and breast. There are the other organs in the body which have cancers, and they can spread tumors to the hand. I've put on a study by Cavett and et al., which had 402 cases of hand tumors. Out of them, 2.5 were malignant, and approximately 1.7 were soft tissues among them. So it just confirms our ratio of malignant tumors in the hand. So we start with the skin tumors. As I said, they are the major chunk of the tumors of the hand. 90% of the malignant tumors of the hand. In the decreasing incidence order, it's the squamous cell carcinoma, the basal cell carcinoma, the basosquamous cell carcinoma, and melanoma. Apart from that, in the skin lesions, we have dermatofibrosarcoma, protuberance, Kaposi sarcoma, sweat gland tumors, and Merkel cell carcinoma. Now, there are a lot of other specialties which deal with this cancer, including the general practitioners in Australia. So we are not going to really touch base on that, how to manage them and how they do it. But it generally does not get referred to orthopedics and hand surgeons. So we might just leave it for the time being. The second topic which I was discussing was soft tissue malignancy. They include different soft tissues of the hand, the epithelioid tissue, synovium, the fat layers, the fibrous layers, muscle, vascular, and the lymph. So these are also other tumors which usually go to the specialty, the tumor surgeons, rather than referring to us. And finally, we have the bone tumors, which would be interested much in today's topic. And there are mainly three of them: the chondrosarcomas, the osteogenic sarcomas, and the Ewing sarcoma. So we'll discuss them in some detail. But my major intention today with this presentation is how not to miss them and how would you evaluate them, because that is what is more concerning to us, that how we should not miss them and how we should go ahead in our workup if we have this sort of tumors with us. So we start with the evaluation. So as everybody knows, lumps and bumps are very common in hand, and most of the time they are benign tumors, but you should always have a high index suspicion in order to avoid misdiagnosis of a malignant tumor. So the basic fundamental part in this is a history, a very good complete history. The second important part is the physical examination with special attention to the affected limb, and then it is supplemented by laboratory radiology and biopsies, and this helps us in determining the proper treatment for the malignant hand tumors. So I'll just run through the basic. So first we start with history. What would you ask when you have such sort of lumps and bumps? The first thing is the time of onset, since when he is having it. The second important point is any change in the lesion. So the patient might be like, I have this bump since like 3 months now, but now suddenly since last week there is a lot of changes going on. It's growing in size, it's changing its color, it's getting more painful, it's now started bleeding, and any history of trauma. So these are the few nutshells which you definitely don't want to miss. Once you have the entire detailed history, then you start examining the lump. So you need to inspect the lump in adequate light source, have a complete look, how does it look. Consider the anatomic structure surrounding the lesion and the possible etiologies for the mass. Next would be start palpating the lesion. Determine the size, shape, contour. What's it feel like? Is it fixed or it is mobile? Is it attached to the surrounding structures or not? As it is a hand, ask the patient to flex and extend the fingers and the wrist in order to determine whether it is arising from a tendon, whether it is arising from a joint space, whether it's arising from the bone. And while you are doing this, definitely don't ignore the rest of the hand. So have a look of the entire hand, go above the extremities and look for lesions anywhere else in the hand. And then once you are done with that, just look for further lymph nodes and other part of the body if he or she has lesions anywhere else. So this probably should be the first step and should go in detail with this. The second one would start now having a workup. So basically we do the routine blood reports, laboratory reports, but you should always have a reason why you do things. So we do not just order reports for the sake of ordering it, but you should have a reason and you should have an answer to it, that why are you doing it. So we definitely would try to get serum calcium, phosphorus and alkaline phosphatase. They are very important to rule out bony metastasis. There are certain tumors which are responsible, and metastatic tumors which are responsible for calcium producing hormones, and they lead to further increase in calcium and phosphorus in the body. If you're suspecting that it might be infectious, then definitely you want to get a hematology profile, CRP, ESR, a full blood count and a hemoglobin level. And if you're suspecting it to be arthritic, then a rheumatology panel and definitely an ESR to assess the state of inflammation. So once you have this laboratory profile with you, now you probably would like to get some imaging. So the basic step is to start with a plain radiograph. The plain radiograph gives you a lot of information, both in regards to the bone and the surrounding soft tissue. Once you find a suspicious lesion inside on the plain X-ray, the next logical step would to go for a CT scan to have a better evaluation. CT scan would give you a three-dimensional picture of the bone, and you might be able to evaluate it much more better. Suspecting that there is a soft tissue involvement, you want to rule out how the soft tissue is, how bad it is, and you can order an MRI so that you have improved resolution in the soft tissue imaging. And last but not least, the bone scans, which we usually use the radioisotopes in order to see if there is increased uptake of the isotope and increased activity of the soft tissue. They're usually restricted to metastatic cancers, and we use for them. Once the workup is done, the next important step would be a biopsy. Now this is very important and challenging. You don't want to put your stick on your needle into the lesion straight away. A lot of careful thought and evaluation has to be kept in there before you put in a needle in any of the lesions which are suspicious for a malignant tumor. This is usually done by an experienced hand surgeon, because the type of incision you should be based on sound technique that minimize the contamination of the surrounding tissues and then allows for additional resections if we have to do it. Our major goal in doing a biopsy would be providing a representative sample to the pathologist, so that we have good amount of tissue to the pathologist so that they can evaluate it better. I've divided the biopsies into three types mainly: the excisional biopsy, the needle biopsy, and the incisional biopsy. The excisional would be usually the goal in case of hand. The needle biopsies are usually best for lesions who have cystic component. And finally, the incisional ones, wherein you have a huge tumor and you probably can't get rid of it completely, so you get a biopsy incisional and then get a definite diagnosis before you proceed with your final management. Once you have done all your workup, your biopsies, what's going on, then would have been a situation where you would now try to manage them. So the crux of management is, first is adequate resection, is the treatment for all malignant lesions, including in neoplasms. And this may include even amputation of a ray or a digit, or even a partial amputation of hand. Clearly, minimizing the deformity created is important, but the goal must be removal of the malignant tissue, which may require a later stage of reconstruction. So we can't leave a malignant tissue inside the hand just in order to be, so that, we have functional improvement or we have a better aesthetic look. So the main goal is remove all the malignant tissue, and then at a later stage consider reconstruction for active use of the component of the hand which is left with. Sounds good. We start with the three tumors which we had talked in between. The chondrosarcoma, they are the most common primary malignant bone tumors of the hand. Quite difficult to differentiate from enchondromas, which we have discussed in the previous meetings. Patient may present with pain, pathological fractures, recurrent fractures. Usually affects the proximal phalanx and the metacarpals. You can see the lysis with a poorly defined border on the radiograph, and definitely a cortical expansion and the extension to the soft tissues. Majority do not metastasize. There is a risk of metastasis about 10%, and the most common site from the hand to go is lungs, and radical surgery offers good prognosis and less recurrence. There's no role usually of chemo and radio in such type of cancers. The second one was osteosarcoma. It's a rare type of thing. Usually presentation is in old age, above 50, with a pre-existing condition. They are expansile with a sclerotic margin. If you can see the x-ray, it's clearly completely sclerotic, or it could be a mixed lytic and or a mixed picture. Affects the metacarpals and the proximal phalanx. They have good response to chemotherapy, and prognosis seems to be better, however, than for the lesions located somewhere else in the body. One more picture of osteosarcoma. So you can see both of them are different, a mixed picture and a lytic picture and a sclerotic picture. And the last one was an Ewing sarcoma. They are highly aggressive tumor, although they are rare, occurs in second decade of the life. May be mistaken for a local infection because they have swelling, fever, generalized malaise. The X-ray clearly shows a lytic destructive expansile lesion with periosteal reaction and soft tissue involvement. And neochemotherapy and radiation therapy combined with surgical excisions have very good survival rates. And last but not the least is the metastatic tumors. They're usually rare, 0.1% of all the metastatic lesions. Primaries are from the lungs, kidneys, prostate, breast, uterus, and colon, as we had discussed before. Occurs in the phalanges, metacarpals with equal frequencies. Confused sometimes with infection because there is usually tenderness, swelling, and redness. Maybe you get confused with differentials like gout, GCT of the bone, and chondromas, aneurysmal bone cysts, which are benign tumors. Radiograph clearly shows a lytic, osteolytic lesions that usually are destroying the adjacent cortical bone. The survival rate is really poor, as the study clearly shows with Abid et al., which I have quoted before too. Just a mean survival of 9.7 months, so usually has a bad prognosis. This was all for today in regards to the malignant tumors of the hand. We have really concentrated on the bone tumors, and we can discuss the rest at some time else. Thank you very much.